Good morning, everyone. Welcome to all the FRCS Part 2 Viva preparing students. Today, we have a very special guest in our teaching session, Mr. Suresh Matthias. He is the consultant urologist from New Cross Hospital, Wolverhampton. He has got wealthy of experience in how to approach the FRCS exams. I will invite him to our show. Welcome, Suresh.
Thank you, Anand. Good morning, everybody. Just to recap, so FRCS Urology is split into two parts. You guys have successfully done part one. Congratulations on that. Part two, trust me, it's not about knowledge. Once again, I'll tell you, because your knowledge has already been tested again nicely by part one. This is all about delivering the message in a precise way within a short period of time. Think about it, for instance, the examiner is seeing you for the very first time. Nobody knows who you are. They could assess you in 10 minutes what you know about a particular station. So you got to be giving very, very crisp, short, sharp answers. The exam scenario will work out as different timetables. You got oncology, you've got stones, you've got UTIs, quite a few stations. And I'm happy to post some slides regarding that. It's extremely important. If you don't know an answer, just be humble enough to say, sorry, I can't remember. Nobody will scrutinize you if you say you don't know, because not everybody knows everything. A high likelihood is that as the scenario progresses, you might remember the answer later, and you could just say, sorry, can I rephrase that question again? And so there's nothing wrong in that. The other thing I would say is progression is vital. So please don't waste too much of time in history taking, clinical examination, etc., etc. The examiners will be bored, especially if you're in the afternoon. The examiners will be tired. They want to, progress really rapid, and they want to get it done. Avoid prompts. So you don't want an examiner to be prompting you for every subtle thing. Few prompts is allowed, but my advice would be you guys should be aiming for 7 in most of the stations. 7 is a very good pass. The other thing is, when you walk into the exam hall, yes, everybody will be stressed. I was stressed. Extremely important you maintain eye contact, nice firm handshake to both examiners. Throughout the exam, throughout the Viva voice, you have to maintain eye contact with both of them. Acknowledge the third person who might be there, who may not be an examiner, could be an observer. It is important. Professional dignity to acknowledge them as well. Pleasant handshake, I did say. Now, I've got this habit of doing this and, doing all sorts of hand movements. Try not to do that. The simple trick is to keep your hand underneath the table. There will be a glass of water. They're very, very nice, all the examiners. They will provide some water. Feel free to have it. But ensure you take the glass once you're done with the Viva station. These are subtle tricks. There will be plenty of sheets of paper, a pencil kept. Again, drawings. If you have to draw something, that's fine. The other trick I've noticed is when they give a scenario, there will be a few catchphrases in the question itself. So as the examiner says, write it on the sheet of paper in front of you. There's no harm in that. So they might say, for instance, a 50-year-old comes in with visible hematuria, is on warfarin for AF, has had an MI in the past, etc., etc. So the few subtle bits you should write down. It is important. So you're going to focus your discussion on that particular patient. It is very important. We did talk about drawings. Drawings is mostly with your technology station, but there will be a few places where it'll overlap. For instance, BPH. Stones wise, Anand is very good at stones, so I don't have to mention, but I've got an interesting picture of RTA and nephrocalcinosis, medullary sponge kidney, etc., which we don't see routinely, but examiners, it's one of their favorites. Pathology slides. Now, we are not pathologists, we're urologists, but we should have some grasp of it. So the most important thing is, before the exam, you're given a clear-cut timetable to say where you're supposed to be. For instance, this is an oncology station, which is just for bladder and kidneys. So remember that. So if the examiner poses a pathology slide, you should know a little bit about it. Nobody expects your pathology knowledge, but at least the basics. Know your validated questionnaires. Again, when you say IPSS score or IEAF score, you should know everything about it. Otherwise, don't mention it. Or just say, sorry, I'm aware of there is a validated questionnaire. I can't remember much about it. There's no harm in that. Trials, again, Anand is a wealth of information. He will give you enough of answers about all of it. To be honest, I passed my exam only in the third attempt. My knowledge was at its zenith the very first time in 2015. It's such a shame because I didn't have anybody to discuss with. Second time, I had some family issues. But the third time, luckily, I found two of my colleagues. Practice and practice. It is not about knowledge. Trust me. And remember, the examiner is always right. So if the examiner says, oh, they don't like a particular way you're answering or the particular answer you gave, just rephrase it. Or stay calm for a few seconds, take a breath, and then answer. You will get the right answer. Right. So I thought I'll give a gentle talk about bladder cancer, for instance. The scenarios could be varied. It could start from a simple basic process of, say, a 60-year-old patient coming in with visible hematuria. How will you proceed with the patient? Versus they might put an ultrasound picture or a CT scan picture to say what it is. Or a mind-boggling bit would be to start with somebody with storage urinary symptoms, who the GP hasn't got any clue about. So you might ask, oh, does the patient have hematuria? And they'll say no. So you have to lead the examiner. Remember which station you're in. You have to lead the examiner to where the examiner wants you. Short, concise answers. When I say progression, from the 10 minutes, wherever the examiner wants to start you, you have to take them up to treatment complications. And that's where you're scoring 7. So if you're stuck somewhere in between, that means you're not progressing. Even if you've done well, that is just a straightforward pass, which is a 6. Most of the stations, as I said, if you get a 7, you're safe. You'll sail through the exam. Wish you all the best. Now, I would like to give you an example how to approach a scenario. Say, for instance, it's a 50-year-old male referred with visible hematuria. So I'm going to time this in 10 minutes. So a 50-year-old male referred with visible hematuria, how are you going to proceed? So you got to state, I'm going to see this patient as a 2-week wait in my hematuria clinic. On the morning, the patient arrives, the patient is seen by the A&P, a short focused urological history is taken, urine for dipstick is done, urine for cytology is kept separately. Our practice in our local trust is to do a one-stop hematuria clinic where the patient has a CT urogram in the morning if it is visible hematuria with up-to-date Usenes. And the afternoon, I will be seeing the patient, taking a detailed urological history, a focused examination in presence of a chaperone, review the investigations from the morning, and proceed with the flexible cystoscopy with their consent. In my examination, in my history taking, yes, you talk about history of smoking, all the risk factors you can think of. I'm not going to elaborate on that. Past medical history, performance status, if the patient is on anticoagulants, any previous urological history, go ahead and examine them. Again, mention a chaperone just to be on the cautious side. Abdominal examination, look for a palpable bladder, gentle examination, and a flexible cystoscopy with a consent. If it's a male patient with a consent, again, you're going to do a DRE and assess the renal tone. Say the next step will be to show a picture of a bladder tumor. So depending on the position of the bladder tumor, so you just got to describe so this is a clinical photograph of a papillary bladder tumor. It appears to be on the lateral wall of the bladder, and there is a small satellite lesion adjacent to this. I would like to look at the rest of the images because I'm concerned 2 papillary tumors are here. It could be multifocal elsewhere as well. Then they say, fine, you've seen this. How would you proceed? So based on the situation of the tumor, my practice is always to get a CT urogram in the morning. Oh, CT urogram has been reported to be normal. How would you proceed? The next step would be to tell the patient this is likely to be bladder cancer, where your CNS has to be involved. You've got to give written information on TURBT. When you mention written information, if you use the BOWS specific consent form, you should know reasonably well about it. And what is more important is there are a few consent forms which are not available for some of the urological procedures. So if you mention a consent form, you should know in and out about it. So BOWS consenting is done, patient is aware, CNS, written information given. Then you'll organize a TURBT. So talk me through how you're going to do a TURBT. In an adequately counseled, consented patient, after a WHO check is done with PPE, I would do a cystourethropy and then go ahead, assess the bladder and do fractionated resections of the bladder tumor. So what are your concerns because of where the tumor is? I'm concerned this patient could get an obturator jerk. So as a part of the WHO check, I would have told my anesthetist that this will be under gentle anesthetic with adequate relaxation. I'll keep my bladder half empty and do fractionated resections and take separate resection biopsy or cold core biopsy of the tumor base. I'll achieve adequate hemostasis with rollerball, preserving the ureteric orifices. Then I'll put a 3-way catheter with a view for a single shot of mitomycin C postoperatively, ideally within 6 hours. So then might go say, okay, so how does mitomycin C act? It's an alkalinating agent, essentially kills all the floating tumor cells. Put it in simple phrases, they'll be happy. You might say, okay, what are the contraindications for giving mitomycin? You could go into UTI, you could go say recent bladder perforation or ongoing bleeding, which you're not going to give. You might say, okay, so what's the evidence behind giving mitomycin? You could talk about Tolley's paper from the UK, could talk about Sylvester meta-analysis. Nobody wants you to give the finer details. So if you say relative risk reduction is this, absolute risk reduction is this, and this is for recurrence with mitomycin C. Fine, you've done that. Patient is in the anesthetic room. Anything else you want to talk about? I said, okay, fine. So post-procedure, I would like to talk to the patient, ensure he's okay, his catheter is draining fine, tell him about the operation findings and prescribe the mitomycin. Okay, so how are you going to follow the patient? So the histology will be reviewed at our uro-oncology MDT, and I will see him in my outpatient clinic in 2 to 3 weeks' time with the results. Fine. Histology shows this. So that's when you can come up with a slide. They might put up a slide. It could be a high-risk non-muscle invasive or a low-risk non-muscle invasive, or you could talk about CIS if it is carpet TCC. Then the examiner will give a clue. Okay, so this is a high-grade disease. It is G3 PT1. What are your concerns? So once again, reiterate to say this has been discussed at MDT. We've reviewed the histology histology slides. We've reviewed the CT urogram images. Histology in particular, you want to make sure there's no CIS present. Number 2 is to ensure there is no unusual variants like papillary, micropapillary, or nested variants. You want to make sure you look at the operation notes to say it's a complete resection. And then they say, fine, you've done all that. It's a complete resection and it's G3 PT1. Then you can ask the examiner, was there sufficient muscles present? Yes, there was sufficient muscles present. So what do you think you should do? Ideally, I would offer a re-resection within the next 4 to 6 weeks. So what's the rationale behind it? So you could say code guidelines and say there's a 20 to 25% risk of understaging if you don't re-resect, and up to 40 to 50% of patients will have residual disease with T1 there. Fine, you've done a re-resection, but there was sufficient muscle in the specimen which was free of tumor. How are you going to treat this? You'd say, okay, the gold standard treatment would be to give intravesical BCG versus an upfront cystectomy, i.e., if these tumors were multifocal, and then it becomes highest risk non-muscle invasive bladder cancer. And if it's a young fit patient, then you can offer an upfront cystectomy. In that case, don't forget a CT chest, please. A lot of people do that. Then they might go into BCG about how it acts, contraindications, side effects. So you could see within time frame how things are going. So that's the pace you need. Pause.
Thank you, Suresh. That was a very nice introduction on how to approach the exam in general. And thank you for taking the bladder cancer as a table. And you really helped us to understand how to explain the Hematuria Clinic, how to explain the TURBT procedure, Mitomycin, and we have gone up to the non-muscle invasive G3PT1. And Suresh, in my view, this whole thing what we discussed could be even two scenarios, isn't it? Say, for example, Hematuria Clinic itself sometimes could be
Absolutely.
one scenario. Yeah.
Absolutely.
Yeah. And sometimes there will be a scenario where the examiner will give the situation like 70-year-old male presented with blood in the urine, cystoscopy showed a lesion, and patient is listed for TURBT. How are you going to proceed? Okay, they can start with TURBT. And sometimes it may be a patient had TURBT first time, G3PT1, had mitomycin in the starting. You are discussing it in the MDT. So they can take it more like TURBT, BCG sort of discussion, isn't it?
Yeah,
what do you
definitely.
think?
Definitely. So one of the scenarios I had was very interesting. It is a 55-year-old man with multiple sclerosis, walks into your hematuria clinic on a wheelchair. He's not anticoagulated, has got good dexterity, has had a long-term catheter for the last 6 years, has got ongoing visible hematuria. So as the examiner is saying, I'm writing down all this. And then he went on, it was a solid bladder tumor. The views were very dismal. What would you do? GA cystoscopy, TURBT, etc., etc. Became more and more interesting in that he had a non-functioning kidney on one side, and the TURBT specimen turned out to be SCC of the bladder. Then they pushed me to say, okay, so what's the risk of having upper tract SCC if the bladder has got squamous cell carcinoma? I said, it's rare. So then it went up to treatment option. I took them to radical cystoprostatectomy. I even said I would be keen to include a nephrouretrectomy on that side because, risk of pyonephrosis in future. It's a non-functioning kidney. Went up to mains 1, mains 2, by the time the bell rang. So took them all the way there. So it's very, very important, the progression in every step. And Anand, you're absolutely right. So when we talk about Hematuria Clinic, many a times they'll just stick with biomarkers, for instance. They might squander a little bit to say, so what are the urinary biomarkers you're aware of? Do you use any in practice? So what is sensitivity, specificity, urine cytology, etc.? But you've got to make sure you rattle out a few answers, then we'll progress.
Yes, because there are so many things to discuss in just Hematuria Clinic itself. Because in a male patient, there is a question, what is the role for doing a PSA? That itself will take few minutes to discuss. And they can refer the old Kader et al. Paper, which belongs to say 1990s. But having said that, there are newer technologies like, for example, narrowband imaging and using fluorescent imaging. Sometimes the scenario may be just evaluation of visible hematuria patient and coming to a diagnosis. So in my view, Suresh, I think the candidates can differentiate what type of scenario based upon how quick the examiner is taking them. If the examiner is slow, talking about cytology, talking about PSA in Hematuria Clinic, talking about various visualization endoscopic methods like narrowband imaging, that means it may be a pure Hematuria Clinic scenario. So they need to slow down and discuss everything in detail. If the examiner skips and takes them directly to TURBT, it means the examiner wishes to lead towards muscle invasive or non-muscle invasive. Of course, these are the two broad candidates. What do you think, Suresh?
Yeah, I completely agree. It can go anywhere. As I said, it can straight away they might jump into bladder path trial, for instance. They might come up with an MRI image of a nasty T2 or a T3 looking bladder tumor. So it might be just a picture, and they'll say, "What do you see there? How are you going to approach this?" So you talk about staging scans again, a little bit of history, but don't spend too much time there because they'll say, that's fine, move on, move on. That means you've got to move on. As I did say, wherever you get stuck, please do remember, don't be like me. The very first first time I was, your mouth will go dry. Yeah, just take a deep breath, 5 seconds, your answers will come out. Or just say, sorry, can I rephrase my answer again, please? Just go back. They are very forgiving. But remember, it's 10 minutes. You've got to do it within 10 minutes.
Yes. Having said that, Suresh, the candidate should be aware that there will be a glass of water. So you will be
Absolutely.
always offered water in all the tables. So don't
Yeah,
feel bad to have a sip. And if you use a glass, you need to take the glass with you. Don't leave it
yeah.
in the examiner's table. And there will be a pen and paper or a pencil and paper there. And I feel it's a very nice habit if the candidates start noting down things like 70 years,
Yeah.
PSA 4.2, CT showed normal, just CT, NAD. So the examiner will feel as if the student is very engaged. And
True.
the last bad thing we want is asking the question back to the examiner, may I know the age again, please, or something PSA value,
Yeah.
please. That looks bad that we are not grasping. In fact, it's very difficult to grasp, so it's better to use the paper. And in some places, like for example, if there is a need for a diagram like a BPH table or something like that, even if the examiner is not asking, you can just start writing and start narrating. That will give you a lot of confidence and a lot of engagement, isn't it,
True.
Suresh?
Absolutely. And that, as you're right, you're absolutely right, Anand, because that shows that you're interested, you're keeping yourself occupied. The exam is about, people always say it is a chat between two consultants, and trust me, it is. And when you do very well, you'll realize it is a chat, and it's got to be a pleasant chat. Remember, the examiner is always right. So never antagonize the examiner. Even if there is a subtle difference in the answer he expects and the answer you give, and the examiner is not happy, just stop. That means you're not doing the right thing, I would say.
Perfect. In fact, we can even phrase it in a different way. Behave like a consultant,
Yep.
prepare with your friends like how your consultants are talking to each other, and walk in to the examination room as a consultant. You will come out as a consultant. If you,
Absolutely. There's no doubt about it.
if you walk in as an SPR, there is a small possibility you may come out as an SPR. So it's better to walk in as a consultant, of course, a humble year one consultant. And the aim of the FRCS exam also to see whether you are fit for independent year one consultant. They're not expecting any more than that. And it's nice, Suresh, you have shared your actual clinical scenario, which has gone up to mains one, mains two. Regarding that, those kind of reconstruction questions, or say, for example, in a different table, post prostatectomy incontinence questions, they will come only in a very fag end of the scenario, like
True,
9 minutes, 9.5 minutes. So
true.
even if you know the labels and main differential features, main salient ways by which you are going to act, say, for example, post prostatectomy, when I took my exam in 2014, they were discussing about master's trial, which is comparing the slings with
Yeah.
artificial sphincter. The answer which we prepared is there is some trial known as master's trial, but unfortunately it's not yet released. But we got master's trial released in 2021. So it's almost like 7 years we are using master's trial without knowing its result. And wonderful results. The results showed that slings or artificial sphincter both are equally good for post-prostatectomy incontinence. It's a groundbreaking result because artificial sphincter, as far as the cost and economics, is sky high.
True.
The male urethral sling is so cheap compared to that. It's a simple
Compared to that.
procedure. So I think these kind of master's trials, if students can bring in whenever there is a chance, that will give most of the examiners are kind of rising of the eyebrow because some of them may not know also. And sometimes the examiners will learn something from the candidate, isn't it? What do you think?
Oh, definitely, definitely. If you're abreast with your knowledge and you can sell it, definitely yes. Um, my um, my stones, Viva, was on a large bladder stone, and it was groundbreaking. The answers I had to come up with, but it was amazing. The examiner was so impressed. I could see the smile on their face. And that's what you should do. Win their confidence. Equally, there will be at least one examiner. Sorry, it's not a criticism, it's a fact. They've been told to do that. At least one examiner will have a very unfriendly face, very serious face, no reaction, nothing. Even then, you should maintain your calm and composure. Just answer nicely. They may not even look at you. You'll try to maintain eye contact. They may not look at you, but that's fine. Answer appropriately. Slow, steady pace, but good progression.
I'm so glad, Suresh, you brought this to the discussion because a lot of times I find the candidates whom I am training, sometimes these examiners are quite intimidating to them, and the student will start feeling that as if they have done some gross mistake. That's why the examiner is not engaging, and they start punishing themselves by going slow or trying to think their own answers and end up unnecessarily losing the game. And even though if they lose the game, it's only one table. And there are 8 tables, 8 into 2, 16 scenarios. So by losing one scenario, I don't think the results will change. And all the past FRCS consultants, post FRCS consultants, we all will agree. We always had one table where we felt definitely it is 6 or less than 6 or even 5, something like that. And we are now post FRCS because there is a easy possibility of balancing out. So once you finish a table, whether it's a super duper groundbreaking, as you said, or it's a heartbreaking table, forget it, go with a fresh face to the next table. I think that's quite important, isn't it?
That's very, very important. That's why the exam is quite fair, because you get a lot of breaks in between. Please utilize those breaks. Don't get stressed out. I know it's human nature to think, oh my God, I've said this in the previous table. That's fine. You can't go back and change it, can you? But make sure you nail it in the next one. So go back, have a coffee, get a bit of fresh air, just go through your notes, be calm. Trust me, you guys will be fine.
Thank you, Suresh. Just one more thing, Suresh. What is your advice if a student has got, say, 1 hour or 1.5 hours break in between 2 tables? Do you think just revising, taking notes, and going through the notes is good, or just closing the book and then just making
Trust
the...
me, Anand, I was perhaps one of those candidates because I had a long gap. This is in Cardiff. So it is in a nice 5-star hotel. I just went to the coffee shop, had something to eat, had a coffee. Then I took a stroll. I just went to the main road, took a short walk and came back. Read for about 10-15 minutes. And that's it. Don't read too much at the last minute. Nothing goes inside. Trust me. Especially because you're stressed. It just doesn't stay.
Yeah, that's well said. Just as a recollection for my exam, it happened in Royal College of Edinburgh, and I booked a room in the Royal College hotel itself, which is just inside the Royal College. So I just walked into the hotel, and I think my room is something like a 3rd floor. So I just went and had a nice fall in my bed for 15 minutes, and then so refreshing. And you will feel as if you are a little bit new compared to the person who is sitting in the exam hall, in the waiting hall continuously, isn't it?
Yeah, absolutely. True.
Suresh, what is your suggestion to do something like 1 week before the exam? Because in my view, as you correctly said, nothing should be read as a new thing. It should be only revision, and whatever your handwritten notes are quite precious at the time. And what do you think? And how do you think you will manage your friends or family in that last 1 week period?
Okay, so let's start from now. So we are in mid-February. Exam is in May. So March, April, May. So we got 2.5, 3 months. Now you can spend all the time talking about evidence for this, blah, blah, blah. You can have long discussions. My practice when I passed, and when I knew definitely I will pass, is that the 10 minutes discussions started a month prior. So I would say the beginning of April or end of March, I think you guys got to practice, keep a study buddy. If your study buddy is tired, sleeping, that's fine. There's something called a mirror. Use mirror on the wall. Trust me, it works. It works wonders. Keep your own phone switched on, which is what I did. I recorded myself to say how I'm reacting. I pose a question, look at myself in the mirror, see how I'm answering. Then I replay and say, well, how can I improve that? Where am I going wrong? That's the best way. On the month of the exam or the last week or two, as Anand said, I do not see the point of you reading anything new. It is just, consolidating your knowledge. And the most important thing is precise practice. Any station, anything which you have never dealt with in your life, within 10 minutes, how are you going to approach it? Patient with sepsis, I would use the ALS protocol and treat it as a urological emergency. I will see this patient with the multimodality tree. Yeah, it's just got to come straight away. Sepsis 6, SOFA score, etc., etc. So it's just got to be really swift, in a nice pace. You shouldn't be rushing the examiner. Equally, you shouldn't be too slow. So it's just a fine balance. The more you practice, trust me, it'll come second nature.
Well said, Suresh. Suresh, any suggestions for the candidates having struggled to sleep? Because I've seen it quite common 1 week before, or sometimes people have struggled to sleep in general, leave alone the exam period. If a student struggles to sleep, especially 1 week before, or especially the day before, where they have nothing to read, they can't read, but they can't sleep, what is your advice?
Happened to me. I had loads of suggestions. Some people started suggesting sedatives. Some people said propranolol, all sorts of things. All I did was, trust me, as I said, it is a nice 5-star hotel where the exam is done. I stayed in the same hotel. I ate to my heart's fill, ate a lot, slept well. Trust me, you will sleep. Good food, early to bed, pray. If you've got the habit of praying, you'll be absolutely fine.
Well said, Suresh. Regarding the day of the exam, a good shower and nice suit as we all plan, nicely shaven, which possibly we are all used to, and good breakfast. What do you think?
Yeah, absolutely. You'll need loads of energy. There'll be a lot of coffees and biscuits, eateries kept there. So when you have your breaks, you're welcome to have it. But a morning breakfast, as Anand said, is a must. I don't have the habit of eating a proper breakfast. I don't know why, but on the day of the exam, I ate properly. It is very, very important. Believe me, it's a tiring day. You got 160 minutes of talking. That's a lot. Imagine it's almost 3 hours with loads of gap in between, but still you're going to be very, very tired.
Well, sir. And on the day of the exam, say, for example, especially the first table, I've seen frequently students are very much struggling to open the mouth. And once the first table has gone smooth, from the second table onwards, they are quite happy in talking. Any tips when there is a blockage in thinking or especially talking, but you know the answer? Any tips, Suresh?
So my suggestion would be slow down a bit or just stop for 5 seconds, 5-10 seconds, take a breath and just go back and revisit the same station again. Happened to me. Again, my pediatric station was a 7-year-old with undescended testis. And remember, there are loads of candidates next to you. So it'll be like a mini fish market. There'll be loads of people talking. It's quite loud. I'm sorry about that. It's not a very quiet room. So you've got to be very focused to listen to the examiner. And as Anand said, the first table, it might be a difficult table or you're just stressed out. That's fine. Just take a breath, leave it for 10 seconds. And the examiner They totally understand. They know everybody's under stress, but that's fine. You will be able to approach a station much, much better.
Nicely said, Suresh. Suresh, for the answers which we know, we are all quite comfortable in putting it clearly and also crisp. There is a situation where the examiner may ask something. It may be like a syndrome, or it may be like a histology slide, or it may be they may ask you to draw some diagram, but absolutely impossible from your side. You don't know what is the histology. You can't even say very clearly even one cell or something. If something like that happens where the answer you don't know anything, what is your advice, Suresh?
So the trick for pathology slides, which you're not sure, is you could start describing it and say, sorry, I'm not entirely sure. I would like to review this with my uropathologist. That's a perfectly reasonable answer. Again, with radiology, although they use iPads, not all the scans are very, very clear. So if things are not clear, you could just say, I'm really sorry. I would like to discuss this with my uroradiologist. Or if it is a scenario, as Anand said, or a drawing, which you haven't got a clue about, I'm really sorry, I can't remember. There's no harm in saying, you can't remember. And trust me, you may remember after a few minutes goes by. But don't waste your time pondering on it to say, oh my God, I can't remember this. No, if you don't know, just say, I'm sorry, I can't remember. They'll move on. They're very forgiving.
I think the time is very crucial, and we should really make use of every second to show what we know rather than dwelling on the questions which we don't know. That's very important. The other thing, Suresh, um, sometimes we tend to give quite in-depth answer to the starting few questions, and we ourselves will feel as if we are going slow. So what is your view? Say, for example, if we are going to examine a patient for increased PSA, we all know we need to do general examination, genital examination, DRE, but is there any way you can make it very crisp so that you won't miss anything at the same time? It's not boring for the examiner talking like a medical student.
Yeah. So say, for instance, race PSA, you said, I would say, after taking a detailed urological history, I would do a focused examination in the presence of a chaperone, general examination, abdominal examination, genital examination, and then with the patient's consent, do a DRE, anal tone, examine his extremities.
Thank you.
Completed. Yeah. Short and crisp.
Yeah. Last question, Suresh. We are almost reaching the 60 minutes. Technology table. This is one of the table where students struggle because it is not something like a clinically relevant table.
True.
Some students struggle in pediatrics because they're not exposed to pediatrics. That's a different ball game. Once you start working in a pediatric unit dedicatively for 3 to 4 weeks, you can master it. But technology table is not like that. Most of the consultants were not very good enough to talk the technology aspect, radiation dose, what are all the parts of a rigid cystoscope, flexible cystoscope. It's very challenging, isn't it? How you tackle the technology table?
So I'm not advocating anybody's book, but the technology book is reasonably good, but it's not sufficient. I had to Google loads of answers and I wrote it down in one of my primary books. I don't want to mention the name of the book though, but you got to bring out salient points and from all the stations and make it as a condensed notes. Some people use flashcards for technology. For instance, when you talk about how does a semi-rigid ureteroscope work, or how does laser work, so you should have flashcards for all this. So about 5 or 6 points for each. That's more than sufficient. So the very first time when I failed, it was about RFA and cryoablation. Jesus, this is back in 2015. Yes, things were being done in the UK, but not every center. I knew about it. I identified the instrument, but then they went to say, okay, so what are the contraindications? So I said, if the tumor is bigger than this and closer to the hilum, etc. Well, the tumor is close to the hilum. Your radiology colleagues could do something to preserve the hilum, to keep it safe. I just got stuck there. I could have just said, sorry, I can't, I don't know. But my mouth went dry. I couldn't answer. So few bits and pieces, I would say you've got to make notes for all of them. BPH station, again, it won't be straight away, they'll show a scope. They might say, okay, you got a 60-year-old man who's got a long-term catheter for retention. He's in clinic with you. He wants to talk to you about management options. So you could tell him about history taking, blah, blah. They won't be interested. It'll be fine. What are the management options for him? Long-term catheter versus CISC versus blood outlet procedure. So when you say blood outlet procedure, it's best. My advice would be to highlight all of them rather than just saying, oh, I would do only this particular procedure. Just highlight all of them and say, for this particular patient, I would offer this procedure for this reason. They like that answer. So they know you're well-versed in all of them. Then they might jump in to say, fine, you spoke about RESUM. So tell me about RESUM or Urolift. Tell me how it works, papers, contraindications, etc., etc. 5 to 10 points of each is more than sufficient.
Thank you, Suresh. Again, that's a very nice suggestion. We will be looking forward in your help heavily. Students will be interested to do few sessions with you, and we will liaise separately. And whenever you're free, we will try to do some mock vivas, and it will be a wonderful resource for not only the person presenting at the time of the viva, also for the other students who are later revising these in our YouTube channel. Thank you very much, Suresh. We really appreciate your evening time.
Thank you very much.